Ladies and gentlemen, let us embark further on this enlightening journey into pediatric dermatology, where every insight gained brings us closer to ensuring well-being of our young ones. Quizzes and case discussions are wonderful ways of brainstorming and keeping our interests alive. Our next presenter is a lovely woman of unmatched caliber and expertise. Very young and dynamic. Professor and Head of Department of Dermatology, Unit 2, Jinnah Hospital, which he has nurtured with vision, hard work and unprecedented strength.
Please welcome Prof.Nadia on the stage.
Thank you so much, Dr. Hira, and thank you, Professor Faria, for inviting me here today for this presentation. And Assalamu alaikum to my dearest legendary teachers, respected colleagues, friends, and students. Now, this discussion, I hope, would serve as an icebreaker because previously they were all lectures. But because of the time constraint, I will not be going into an interactive session, or I will not be stopping to take your input. You can just brainstorm in your minds, and at the end, the quiz prize would be given by Harun Bhai to the person who's raises their hands that they thought of the best differential or the diagnosis. So I start here. This is a 12 years old male who presented to us in the dermatology OPD of Dermatology Unit 2, Jinnah Hospital. And he is a resident of Akara. He presented on the 18th of January with the complaints of recurrent frunculosis, multiple episodes of chest infections and recalcitrant leg ulcers for the last 4 to 5 years. These were the problems. So I will give you a few seconds to brainstorm and think of a relevant differential in this case. Now we'll move on. I have put this differential. If you were thinking of some of these things, we thought of primary immunodeficiency syndrome. Then we have sickle cell disease in mind, Shidaki-Higashi syndrome, and beta thalassemia, Werner's, and proliferase deficiencies. So, we have a lot of common things which are very common in our everyday practice, but sometimes we do think of certain uncommon conditions as well, especially when there is, yes, sorry, would you like to say something? You're raising your hand? Sorry? Raising the hand for the answer. Okay, you can be a bit patient, we'll come to the discussion as well. Just as I said, because of the forum and the time constraints, we will not be going into a very, a discussion or an interactive session. So the presenting complaint, when he came to us, because those complaints were off and on for the past 4 to 5 years. When he came to us, he presented with painful leg ulcers for the past 1 month, and there was abdominal pain for the past 2 to 3 weeks. The history was that the ulcers, though they were there for the 4 to 5 years, he was going to various doctors and he was taking treatments. He was admitted multiple times, but the ulcers still, they were relieved for some time, and then they again relapsed after a few days or weeks or months. And there was a purulent on the ulcer which we saw, which he presented. It was having a purulent discharge. He complained of that discharge for the past 1 month. And there was pain and swelling associated with it of the lower shin. The diffuse abdominal pain was radiating to the left hypochondrium. There was anorexia and abdominal distension as well. He also complained of chest infections, which was off and on associated with high-grade fever. And he also complained of weight loss, which was about 4 to 6 for the past 6 months. There was no history of certain problems, like there was no trauma at the site of the lesion at any time. There were no lumps and bumps of the body, no swelling of hands and feet. There wasn't any productive cough. There was no history of easy bruisability and any premature graying of hair or any polyuria or polydipsia. On systemic inquiries, he had delayed milestones. There was cognitive impairment. And we referred to a psychiatrist as well, and in the hospital, and they labeled him as a conversion disorder. And there was headache off and on. There was no history of vertigo, auditory or visual impairment in the patient. In the serious inquiry, there was exertional dyspnea, but there wasn't any history of palpitations, chest pain or orthopnea or PND, and there wasn't any hemoptysis or wheezing. In the GI, apart from the abdominal pain and distension, which I have already mentioned, there wasn't any significant symptom, and there wasn't any genitourinary symptom as well, and there was no muscle aches, joint pains or swelling of the joints. In the past medical history, there wasn't any relevant finding, and he was being treated previously in the past 4 to 5 years by multiple antibiotics and oral medications as well, and he was being given painkillers for the pain in the ulcer at the ulcer site. The family history, he was born to consanguineous parents, but the siblings were all healthy and there wasn't any history of psychiatric illness in the family. He belonged to a lower socioeconomic status. Now we come to the examination of the patient. This was our patient. He was a young boy, but he was pale looking. He was not very well oriented in the time, place, and his vitals were stable. There wasn't any jaundice, cyanosis, polyuria, or any palpable lymphodes or leukonychia. But he was having these features. As you can see, there was prognathism, there was hypertelorism, there was proptosis and depressed nasal bridge. And these are the bitoid spots in the eyes which the patient was having. This is a closer look of the bitoid spots. And he also had a high arched palate. These are the nails. In some of the fingernails, there was finger clubbing. Here you can perceive this. And this is the ulcer with which he presented to us. This is the leg showing a crusted ulcer. There is crust over the ulcer, there is hyperpigmentation, there is atrophic marks, and then we have this another picture showing the swelling of the ankle as well. This is another, and you can see there wasn't any varicosities and the pulses were normal on examination. There are multiple atrophic scars and hyperpigmentation over the legs. On systemic examination, the abdomen was tense and the left hypochondrium was tender on palpation and the spleen was palpable. The bowel sounds were audible. There wasn't any joint deformity or hyperextensibility of the joints. The rest of the CNS and the CFS examinations were normal, and the respiratory examination was also normal. Now again, I would like to ask you the differential diagnosis after the history and the examination. Here you can give me your input. Ji, Yasam. Prolidase deficiency. Yes. Good. These are the investigations of the patients. He was anemic. As you can see, the HP was low and the platelet count was also a bit on the lower side. The rest of the LFTs were normal, but the gamma GT was raised. The chest X-ray also was normal. But on cervical X-ray, we saw these features. I think we don't have the radiologist over here, but these were the features reported by the radiologist. There was increased curvature of the cervical spine. Along with these features, there was sclerosis of C1 and C2, a butterfly vertebra, and an omovertebral body. I then read what is an omovertebral body, and this is an excessive bone which is over the scapula, over the posterior edge of the scapula. Rest of the investigations, when we got the gamma globulins, they were raised. The IgE, IgA and IgG were also raised. The complement levels were low, C3 and C4. And on the ultrasound, there was massive splenomegaly, 22.5 centimeters. So the final diagnosis after these investigations was prolidase deficiency. Very briefly, one or two slides about prolidase deficiency. I'm sure we are all familiar. It is a rare autosomal recessive disorder, and there is mutation in the peptidase gene. There's deficiency of the prolidase enzymes. This prolidase enzymes helps us in inflammation, in carcinogenesis, in wound healing. Now this is the suggestive criteria which I found, like we do not have a consensus clinical criteria like we have of certain dermatoses like atopic dermatitis and other conditions, but here we haven't got a consensus criteria, but these are the suggestive findings, like the findings in our patient, and the frequency has been reported, like these findings are reported in like ulcers are reported in 62% of the cases which have already been reported. Like there are less than 200 cases reported worldwide of prolidase deficiency, and I think I may be wrong, but I searched and I think this will be the 4th case report in Pakistan, and it is being submitted by my team and my senior registrar, Dr. Humaira. I think she's sitting here as well. And all of them worked hard in getting all the calls from all the multiple departments, because this is a multidisciplinary approach in such a patient. So we found legs, ulcers, recurrent infections, dysmorphic facial features and cognitive impairment, and skeletal findings, splenomegaly, immunological abnormalities and anemia. The biochemical findings, which are the diagnostic confirmation world over, we were unfortunately not able to get these, because when we asked certain labs, they were not doing them, but the genetic testing was being done, but it was for 1.5 lakhs, so we could not go for that. But we are following the patient. He is being followed up for splenomegaly, because when we consulted the PEDS department, they said that you should go for a bone marrow biopsy as well, so they are looking after the patient, and a neck collar was advised for the cervical spine. Then there were vitamin A drops for the bitoid spots, and psycho education was done by a psychologist in the hospital of the parents. And what we should do for surveillance of the disease progress, we should look for the malignant change in the skin ulcer. We should have regular eye evaluations of the patient, dental evaluation as well, because the things are reported in the literature. We did not find any dental issue in our patient. Then counseling for rigorous sports, because he had splenomegaly. And assessment for mobility and timely diagnosis of infections and educational needs should be addressed of the patient. Thank you so much. Thank you.